Hello and welcome everyone to another session of the eMRCOG up-to-date series. So it's a new guideline, so it's a new meeting between us, my friends. Let's have a look, okay, to what is the update in this guideline, discussing the IUFD. The previous version of this guideline was quite old, right? And the changes that appeared in the guideline, yeah, it's not very much, okay, thanks God, but of course it will make a difference, especially that it's an important for the practice and important also for your exams. The IUFD or the stillbirth appear as a single best answer questions mainly in the part 2 exam and part 1 for the MRCOG, and it appear as a station in part 3. So in part 3, you know, it can be one of your 14 stations, right? So very important, and it can really carry a lot of marks, especially if they ask about some of the new information. Now on the screen, if you can see, this is the patient information leaflet, which is a new one. Okay, the original one was published by the July 2012. Okay, this is like 12 years ago. And now updated in October 2024. Okay, so if you are interested to read the patient information leaflet, it will give you a short view of the guideline, and it will give you also a very important practical point for the OSCE exams, right? So first we'll go to the guideline, then we will review the patient information leaflet and the most important questions, okay, that a patient can ask you, okay, or interested to know its answer. So it started like every other guideline with the background epidemiology, and they will give you a definition, which is important again, because it's a legal definition, okay? So the stillbirth is defined as a baby delivered with no signs of life known to have died after 24 weeks, completed weeks of pregnancy, while the late intrauterine fetal death refers to babies with no signs of life in utero after 24 completed weeks of pregnancy. So, my friends, what is the difference between a stillbirth or late intrauterine fetal death, which comes in the, you know, legal questions in the exams? The difference is that baby is out, baby is delivered. So this is a stillbirth, right? So it's legally defined as baby delivered with no signs of life, right? Known to have died after the 24. But late intrauterine fetal death means that the baby is still inside, and from the definition, it's intrauterine, correct? So it's still inside the uterus, is still not delivered yet. So no signs of life in utero after 24 completed weeks of pregnancy, which is a common recall question, and people get it sometimes wrong if they don't know the difference between the two definitions. The rate of the late IUFD, okay, also number is important, because we used to have what is the rate of a stillbirth, what is the rate of IUFD. So now it's look 1 in 250, okay? That's very important. And if we compare this to the sudden infant death syndrome, this is, of course, it's not a common at all, thanks God, okay? So the rate of the sudden infant death is, anybody have an idea about it? It's 1 infant death per 10,000 live births, okay? So still numbers are important. The highlighted one is the most important one, okay? Is more important than the others. Babies born to women living in the most deprived area are likely to be stillborn. This is again a question of the exam, okay? So if you compare between the stillbirth rate in deprived areas compared to non-deprived area. So the rate in the deprived area is twofold increase. Mortality rate remain exceptionally high for fetuses of the minorities in the UK, unfortunately, Black and Black British ethnicity, okay? So stillbirth rate are over twice those for fetuses of white ethnicity. So those are, again, recall question. It's the same information that appeared before from the NICE guideline of the antenatal care. At the introduction, it was there. It's the same information that is appeared before in the maternal morbidity and mortality report, right? So it's an exam question also, so I assume it's important. For the diagnosis, we are still the same, right? So we have auscultation and CTG should not be used to diagnose the late IUFD. However, we recommend the real-time ultrasound. Again, it's a repeated and very easy exam question, right? And this is for recall. So views that can often be augmented with color Doppler of the fetal heart and umbilical arteries, okay? So the real-time ultrasound will allow you the visualization of the heart views, right? So very important, okay, if the patient asks about the feeling of movement after the confirmed fetal death by 2 doctors, okay, that you will tell her, okay, that is most likely, okay, to be a passive fetal movement. It's important if you're counseling a patient in OSCE exam, okay? So the patient will be prepared if the patient have diagnosed of late intrauterine fetal death and she still have the baby inside. So part of the counseling that you will warn her or you will make her prepared to feel the possible passive fetal movement. If the woman reports a fetal movement after the scan to diagnose the late IUFD, a repeat scan should be offered. Okay, so this is again, this is a theory question. Okay, so a repeated scan will be offered even if you think that this is only a passive fetal movement, you have to repeat the scan. This can make an eMRCOG question for you guys. If you look to the risk factor, okay, for the late intrauterine fetal death, you will find that they have divided this risk factor into a non-modifiable risk factor or a potentially modifiable. The non-modifiable, those are risk factors that we can't change, right? But they potentially modified those things that we can do something for that. So, for example, the non-modifiable is nulliparity, maternal age above 35, maternal age below 20, Black, Asian, and non-white women, previous stillbirth, previous adverse pregnancy outcome, like preeclampsia or preterm birth or fetal growth restriction, multiple pregnancies and advanced gestational age more than 41 weeks, FGR and or a small baby for gestational age, low educational attainment or reduced fetal movement, thyroid disease, thrombophilia, malaria, infection, COVID-19 infection, other infection, and cholestasis, systematic lupus erythematosus, and antiphospholipid syndrome, renal disease. For the potentially modifiable risk factors, we find that we have pre-existing hypertension, obesity and overweight, smoking more than 10 cigarettes per day, alcohol use, illicit drug use, going to sleep supine, and living in area of most deprivation. So those are the risk factors which can make a single best answer questions in your exam. For labor and birth, my friends, remember first, okay, that cesarean birth will need to be considered for some patients, but this is not the recommendation for all the cases with fetal death. Of course, the vaginal birth is recommended for most women. Late intrauterine fetal death is not a contraindication to a full birth in suitable circumstances as well. Okay? When you will advise the woman to think about induction of labor, what do you think the time when we can discuss this with her? Anybody know what is the answer of this question? What do you think? What is the time when you will recommend the time of the delivery, or the woman go for like induction of labor or even a cesarean if it is have any obstetric indication for it? What do you suggest, guys? Immediately or after? Okay. 1 week? Look, my friends, first of all, yes, I like this answer, which say it depends. Yes, Dr. Inko, of course. Okay. So it depends on the circumstances. How? I'll tell you. If the woman, for example, she had severe preeclampsia and complicated with a fetal death, will you just keep the baby, or you will advise the immediate delivery? No, you will, yes, no, not keeping the baby, you will advise for the delivery. Yes, exactly, right? If you have a case which have another complication like complicated infection or deterioration in the maternal condition, then also delivery, right? If you have a proof of infection, then you will go for delivery, for example, right? If the woman requested that, because some women, you know, they have that, you know, feeling that if the baby stayed inside, okay, this is will increase her emotional burden, right? So this is will be considered as well, okay, for maternal request, right? However, women who are physically well with intact membranes and no laboratory evidence of disseminated intravascular coagulation, DIC, should be advised that they are unlikely to come to a physical harm if they delay labor for a short period like 48 hours. But they may develop severe medical complication and suffer great anxiety with prolonged delay. Okay? If the woman delayed labor for more than 48 hours, what are the precautions that we need to take? Yes, it will be testing for the DIC. Yes, and we will recommend that this will be done like twice weekly. Okay. Look, my friend, I have a question in the chat box. Please, I would like to clear it because as I told you before, you know, this secret that I am most probably have ADHD. I don't know why, but I'm distracted. If there's a question, I want to answer it, you know, I have this urge to answer the questions. So I'm sorry to interrupt your thoughts. Your friends here in the chat box said that in Dr. Kunji book, okay, there is a question, SPAs, says what is the best to diagnose IUFD? And the answer was real-time ultrasound with Doppler. My query is that Doppler needed always to confirm IUFD or in just some circumstances as mentioned in this GTG. So Dr. Isra, my dear, okay, as you can see here in this guideline, it's very clear real-time ultrasound because it allows direct visualization of the fetal heart views that can often be augmented with color Doppler of the fetal heart and umbilical cord. So if you are performing a real-time ultrasound, okay, So you will have the advantage, okay, to use the Doppler, right? So the answer is absolutely correct. And this is one of the points that is not changed from the previous guideline and this one. Okay. So, my friends, now we come to the point of how should labor be induced for a woman with unscarred uterus. So if the woman have no scars in the uterus, now we will advise a combination of mifepristone and a prostaglandin preparation. So the prostaglandin that is recommended is the misoprostol. We all know this, right? And this is the first intervention for induction of labor. The doses are very, very important, okay? So fixed dose that I will start with, it's a single 200 milligram dose of mifepristone is appropriate for this indication, followed by, according to the gestational age, the dose of the misoprostol will be changed. If we speak about from 24 to 24 plus 6 weeks of gestation, I will use 400 microgram of buccal or sublingual or vaginal or oral misoprostol every 3 hours. So it will be 400 every 3 hours. Okay? If you are between gestational age 25 to 27 plus 6, then use 200 microgram buccal or sublingual or vaginal or oral preparation of the misoprostol every 4 hours. So now the total dose will be, if you think, 200, okay, the woman, she had like 24 hours, for example, let's say, okay? So every hour she's taking 200, every 4 hours she's taking 200, 200, 200. So that's mean, what is the total dose? Yes, 1,200, okay? So if we, per day, yes. So if we said from 24 plus 0 to 24 plus 6, this is double dose, okay? So, and also the duration every 3 hours, okay? So it will be like 8 divided, multiplied by 400, that's mean 200. Yeah, 2,400, yes. So my friends, from 28 of gestation, look, my friends, here there is a difference between the oral dose and the vaginal dose. Vaginal dose, it will be 25, 50 to 50, okay, microgram of vaginal misoprostol every 4 hours. Okay, so if we say like this is a 25, and they will take per day for 6 times, that's mean 150 up to 300, right? Okay, yes. So see, the dose is much reduced per day. And now let's have a look at the oral. Oral, this is 50 to 100. If you give it oral from the 28 weeks, the dose will be 50 to 100 microgram oral every 2 hours. You can see the frequency is more, okay? So if you are in the exam, okay, and let's say the examiner just give you options between the 200, okay, microgram buccal or sublingual in a patient who have diagnosis at 27 weeks, right? And he give you the options, okay, between buccal, sublingual, vaginal, oral. So even if he did not give you here any preferences, okay, which route sounds to be that's more effective and less of the complication or side effect? Okay, so you will go to the vagina. Okay, so if you have here from 28 and the choices between 25 to 50 vaginal every 4 hours, or 50 to 100 oral every 2 hours, which one you go for it? Again, vagina. Okay, I'll tell you why, my dear friends. First of all, the low dose misoprostol preparation are now available in the UK. Okay, and even it was mentioned in the induction of labor NICE guideline, which is published 2 years ago, or maybe more than 2 years now. And here in this guideline, look, there was also a scientific impact paper comparing between both of them. Here in these books, take care, okay? Because here they can, give you a question, right? And this is the explanation of that one. Vaginal misoprostol is as effective as oral, but associated with fewer adverse effects. Okay, so vaginal misoprostol, like the 50 microgram, had, or even more, had the highest probability of achieving a vaginal birth within 24 hours. And the evidence level in this is 1+. Is that a high quality evidence or no? Of course, yes. Okay, so a misoprostol use for the induction of labor following a stillbirth is off-label in the UK, but of course it's available now. For third and second trimester termination of pregnancy, vaginal misoprostol for induction of labor appears equally effective as the gimiprost, but it's much cheaper. Okay, so they are advocating the use of the vaginal misoprostol, and it's associated with higher probability of achieving a vaginal birth within 24 hours. Okay? Yes, means if he give you, yes, as we said, my dear, okay, this is like growing evidence now. Also, the preparation is now available in the UK, the low dose of the misoprostol, and it can be given vaginally, can be used for the cases of induction of labor for normal pregnancies, or in the cases of the IUFD. And the studies found that we have more or higher, chances of achieving spontaneous labor in the IUFD and spontaneous delivery in the live babies. Okay. It's not about the total dose, my dear. It's safe, no problem, okay? But we expect that we find a good result, okay, from the third dose, okay, and up to total 1. Yes, it's up to total 1 day or like 24 hours. This is the maximum allowed, okay? Now, this is something that you need to take care of, and please keep a note for that. Why? Because it can be a bit conflicting, but if you get the trick in this part, okay, everything will be just clear. What is the best practice for induction of labor for a woman with a history of lower segment cesarean birth before? Abortion is different from IUFD, Dr. Adila, please. Yeah. So in general, I would say if I have induction of labor for a woman with history of cesarean section, okay, then we can go for the mechanical methods, right? That's in general. Yes, Dr. Sana, my dear, yes, this is in the induction of labor guideline, which is yes, okay? But now let's focus here. So we do have advice, personalized guideline, very clear that we can use the mechanical method for scarred uterus, correct? Yes, okay. Here, please focus with me, okay? Because there's here something a bit different that you need to take note of it in this guideline, in the IUFD guideline. Misoprostol can be used for women with previous cesarean birth or other transmural uterine scar between 13 and 27 plus 6 weeks of gestation. Okay, so for pregnancies more than 28 weeks of gestation, there is insufficient evidence available to recommend a specific regimen of misoprostol, okay, to use in women with a scarred uterus. So please, my dear friends, take a note here, okay? Because we speak here about the late intrauterine fetal death, 24 to 24 plus 6, okay? That 400 microgram every 3 hours, 25 to 27 plus 6, 200 every 4 hours. But once we have more than 28 weeks of gestation, then what do you think the advice is? That there is insufficient evidence, okay, about a specific regimen of the misoprostol. No, no, no. We are coming now, Dr. Anita Media. We are coming to the previous two cesarean section. Okay. Women with more than 2 lower segment cesarean birth or atypical scar should be advised that safety of induction of labor is totally unknown. Okay. Women should be informed that 2 to 3 times increase in the risk of uterine rupture and around 1.5 times increase in the risk of cesarean birth in induced and augmented labor compared with spontaneous VBAC labor. So here I am asking my friends, especially those who are having OSCE exam, right? If the woman is asking you about the risk, okay, of induction or augmented labor with a scarred uterus compared to a spontaneous VBAC, what would be your answer? Is it the same risk of induction of labor? No. Risk of the uterine rupture, around 1.5 time increase, right? VBAC is not ordinarily recommended for women with 3 previous cesarean births, previous uterine rupture of the upper segment incision after 28 weeks of gestation with a previous cesarean, and cervical ripening with a transcervical Foley catheter has been associated with uterine rupture rate comparable to a spontaneous labor. So it could be helpful, especially in women with unfavorable cervical examination. So if I have to choose, okay, for pregnancies after 28 weeks, if I have to choose between the mechanical method or if I need induction or the misoprostol, which one you will go for it? Yes, of course, that this will be the mechanical. Okay, that's very important. Okay, so my friends, what came in this guideline, and I would like actually to take a screenshot from the table, okay, by the guideline and send it to the group. Okay, this is about the use of the misoprostol between 13 and 27 weeks plus 6 days, okay, but not after this. Okay, I hope you have received this one already. Okay, so what about the use of oxytocin? Is it okay to use oxytocin while you are augmenting labor or inducing labor for a case of IUFD and she had a scar? Would that be okay? Yes or no, or it depends? What do you think? Look, my friends, it's written in the guideline, okay, with a strength evidence or the evidence quality of 4, okay, and this is the least one. However, it's okay. Let's see what the guideline says. The guideline says in this part that the oxytocin augmentation can be used for VBAC, but the decision should be made following a discussion with a consultant or obstetrician with equivalent training, okay? So it will depend and it will be a consultant decision, okay? But it's not contraindicated. So you have to, know this part for the tricks of the MRCOGs because they like to ask about the areas, okay, where the common answer, it will come as no, okay, but the guideline is still say, yes, it may be used, but only after a discussion with a senior obstetrician, okay? While you are, yes, it's individualized, yeah, with the consultant opinion only. Okay, so what is the precaution when you are inducing labor for a woman who have a scarred uterus? So, in the cases of live baby, what we do is we keep the CTG on, right? And we have learned that the changes in the fetal heart rate as considered as early signs of scar dehiscence or rupture, correct? So here in the late IUFD, I don't have fetal heart rate, right? So now what is the alarming signs or symptoms for me? Okay. So guys, clinical features which include maternal tachycardia, atypical pain or vaginal bleeding, high head-on examination, shoulder tip pain, hematuria or catheter specimen, and maternal collapse. Those are all considered as clinical features of uterine rupture. Okay? So tachycardia came here for the signs, other clinical features. Okay, it came early, right? Yes. So other consideration, if you have a case of group B streptococcus, she is a carrier of group B streptococcus, and she had a late IUFD, will you give her antibiotic prophylaxis against group B? Yes or no? No need. Yes, it's no need. Women who are RH negative, how you will manage them? what is the recommendation? So we have learned before that once we have a woman who have Rh negative, okay, at the time of the diagnosis, we will advise the anti-D, right, with the Klein-Howard test. And we said that anti-D should be given within 72 hours from the time of the diagnosis of the fetal death, right? Correct? Yes, we have learned this. Okay, so here, my friends, please be careful that for the woman who is rhesus D negative, it should be offered the Klein-Howard test undertaken urgently to detect a large fetal-maternal hemorrhage that might have preceded late IUFD. Anti-RHD should be administered as soon as possible after presentation. If there is a large fetal-maternal hemorrhage, the dose of the anti-D will be adjusted, right? So we all know that the dose, usual dose or the recommended dose after deliveries will be 500. 500, this is to cover 4 ml of the hemorrhage, correct? So if you have a large fetal-maternal hemorrhage, then how you will titrate the dose? Simply for every 1 ml of hemorrhage, what you will give? You will give 100 to 125, okay, of the dose, right? Okay, so you will calculate the dose and give it to the patient. But remember, in the cases of the large fetal-maternal hemorrhage, after you adjusted the dose, the Klein-Howard test should be repeated when? It should be repeated at 48 hours. 48 hours. So you will do a Klein-Howard test. You will give the anti-D, right, and adjust the dose according to the fetal-maternal hemorrhage result. If the large fetal-maternal hemorrhage is detected, you will repeat the Klein-Howard test when you will repeat it at 48 hours to ensure the fetal red cells have cleared. Okay, friends, so when to repeat the Klein-Howard test, this can be a possible exam question, right? If there is evidence of DIC, then please remember that regional anesthesia, of course, is contraindicated in this case. Okay. How you will manage the cases of the stillbirth, okay, after delivery. We all know that the event itself of fetal death, the late intrauterine fetal death, increase risk factors for the VTE, okay? And here, it's very clear that they wrote up to 6 times compared with a live birth. Late IUFD in current pregnancy should be considered as independent risk factor for VTE. Okay, friends, so please be careful because in the postpartum, the VTE risk assessment is very important, right? Of course, after ruling out any DIC, right, the VTE risk assessment should be done. You count the IUFD, okay, as independent risk factor, okay, and the woman should be advised that the dopamine agonist also for the suppression of lactation. The dopamine agonists successfully suppress lactation and are generally well tolerated. So they will ask you also about the medication of a choice. Then you will choose from the dopamine agonist group, you will choose the cabergoline. The cabergoline may be superior to bromocriptine, okay? In this case, dopamine agonists are cautioned for use in women with hypertension or preeclampsia. So please be careful as well. Okay, my friends? That's very important, okay, as managing the cases of labor. As I told you, a lot of exam questions comes here, and also potential station in the part 3 exam, they will ask you about how will you manage the labor of this case, okay? What is the things that you will take care of after the delivery. Okay. How about the investigation that is required after the delivery? We all know, my friends, okay, that we will run investigation for the mother. We would like also to have a post-mortem examination, okay, for the fetus. And to do this, you need to have a consent. And the consent, the type of the consent, okay, would be written or a verbal one. It must be written consent, okay? So look, my friend, here, the best practice guidance for cytogenic analysis of the baby. All parts should be offered cytogenic testing of their baby, all parents, sorry, of their baby, which should be performed after written consent is given. So you will not run any investigation on the baby without the parental parent give you a written consent. 6 to 13% of stillbirth babies will have a cytogenic anomaly. So this is also like asking you about the possible finding, okay? So the cytogenic abnormality will be found in 6 to 13%. Karyotyping will be useful to detect any cases of mosaicism, for example. However, it can underestimate the contribution of genetic anomalies to a late IUFD because up to 50% of karyotyping attempt cell culture will be unsuccessful. This is a single best answer question that came before already in the exam about the rate of the unsuccessful cell culture, okay? 50%. Microarray analysis, which provide more result than karyotyping, is not only detect aneuploidy, but also detect copy number variant, okay, like a smaller deletion and duplication, not detectable by the karyotyping, but has this advantage that it's identified variation of unknown clinical significance. And actually, when they tell you variation of unknown clinical significance, this is not an answer. Okay. The QF-PCR can be performed on directly extracted DNA. So those are the tests that can be done for the genes, right? So please here, remember again, karyotyping. What is the special thing about the karyotyping? That there is 50% failure or unsuccessful cell culture. Microarray analysis, it's better than the karyotyping, okay, can help you to detect not only aneuploidy, but the copy number variant. But its disadvantage is the result they will say it identified variant of unknown clinical significance, okay, which can be sometimes conflicting to the parent. PCR, okay, it can be performed directly on DNA. Before you take a biopsy from the placenta, you need to take care that should not be placed in formalin, okay? And the placental biopsy, it will be taken approximately 1 cm diameter, should be taken from the fetal surface close to the cord insertion to avoid tissue of the maternal origin. So I think that there was a previous exam question asking you about the site where you will take the placental biopsy, and it should be from the fetal surface or it should be from the maternal surface. So the answer is simply from the fetal surface, okay? Cord biopsy can be undertaken and it should be above about 0.5 cm, half cm in length, okay? And all the specimen should be put in a sterile tissue culture medium of lactated ringer solution, okay? The perinatal postmortem autopsy, okay, so again, consent must be given to any invasive procedure for the baby, and a prior discussion should be done with a senior obstetrician or midwife with appropriate knowledge, given the nature and specific of the perinatal postmortem. Parent who decline full post-mortem examination might be offered the limited examination, okay, like sparing certain organ, but this should be discussed with the prenatal pathologist before being offered, okay? If imaging is the only option, means that the parent did not sign for the prenatal postmortem autopsy, then in this case, ultrasound and MRI remain the first line imaging non-invasive investigation of prenatal autopsy. So please be careful, my friends, if you are counseling a patient in the part 3 about the postmortem examination. So if the patient declined the postmortem fully, okay, either the full or the limited type, okay, then you will speak about the importance of imaging like ultrasound and MRI, okay? For you guys who are attending written exams, this can be also a possible single best answer question about parent again who declined to give consent for postmortem. So ultrasound scan and MRI remain the first line imaging, okay? Independent or full postmortem placental pathology, therefore, should be offered even if the postmortem examination of the baby is declined. Okay, so they can do the investigation even if they don't want autopsy. Okay, how about the care of pregnancy following stillbirth baby? Is there any specific precautions? Any specific precautions, my friends? The woman who had a previous stillbirth. Yes, of course, there is a risk of recurrence. Okay, so the single most important risk factor for recurrent late IUFD is the history of a previous late IUFD. Okay, this is a rule that applies to a lot of conditions in the pregnancy. A previous late IUFD is associated with 4.8-fold increased risk of late IUFD, and small for gestational age infant are found approximately 2 to 3 times more frequently in women who had a late IUFD than live birth. Okay, so rate of small for gestational age 2 to 3 times more frequently. Okay, assessment of the fetal growth is recommended in subsequent pregnancies. Okay, and very important, you remember, if the woman in the FGR and small for gestation age new guideline, if the woman have a stillbirth and the baby was appropriate for gestational age, what risk is that for having FGR in the current pregnancy? Is it a moderate risk? Is it a minor risk? Is it high risk? If the baby who died stillbirth and was appropriate for gestational age, this is a moderate, okay? And they have used the AGA, means appropriate for gestational age, is a moderate risk factor, correct? Okay, if the baby who died was small for gestational age or FGR, okay, it's a high risk, right? So if it was a small, now it's a high risk of having FGR in the current pregnancy, right? Yes, it's a high risk. So the stillbirth, you will notice in the new guideline of the small for gestation age or the FGR, you will notice that it's now repeated in the moderate risk group and in the high risk group. That will depend on the previous baby was appropriate for gestational age, then this is moderate, or the previous baby was small for gestational age or FGR, this is high risk. Okay, so the frequency will be depending on of the follow-up will be depending on the new guideline of the FGR, of course, in details. So, dear friends, Assessment of the fetal growth is recommended in subsequent pregnancy at minimum every 3 to 4 weeks from 26 to 28 weeks of gestation. But please, okay, here you will have, okay, in the cases of the eMRCOG, if it comes, okay, you will have to apply the small for gestational age for the exact frequency of follow-up. Low dose aspirin, 150, may be offered to all women with a previous IUFD, either associated with placental dysfunction or unexplained or in unexplained cases, right? So you have a case with a previous IUFD to take care of her in the current pregnancy. One thing that you will offer is the aspirin, right? Regardless of what was the cause, okay, of the IUFD before, right? One thing also that you will advise screening and follow up before FGR or small for gestation age, and this will depend on the previous size of the baby about the frequency of the follow up. But at bare minimum, it will be 3 to 4 weeks. This is the bare minimum. Women with a previous unexplained late IUFD, or if there is signs of macrosomia or placental finding consistent with glucose dysmetabolism, such as delayed villus maturity or fetal vascular malperfusion, should be recommended to have a screening for GDM. So here, my friends, if she had previous unexplained late IUFD or macrosomic baby, or a placental finding suggestive of glucose dysmetabolism, such as delayed villus maturity or fetal vascular malperfusion, this will have GDM. So GDM is for all, or GDM is for those group of unexplained or macrosomic or placental problems suggestive of glucose dysmetabolism. So a group of the people who have late IUFD in the future will have GDM screening, okay, but not all. Okay, women in subsequent pregnancies after late IUFD should be offered induction of labor or birth by how many weeks? Shall I keep them to 40, 41, 42 weeks? By the 39 weeks, a very important advice for your own practice and also for the exams, both written and OSCE exams. In this table, my friends, you will find that here, test, okay, that you will offer and information about each one. Reason for the test, okay, additional comments or the timing. So, parenteral blood for karyotyping, what you will do for it. This is the reason to do this. The parenteral balanced translocation or mosaicism can be detected, but when it will be indicated if fetal unbalanced translocation is found on the cytogenic analysis, or if it's recommended by the genetic counselor, or fetal genetic testing fails and history suggestive of aneuploidy, like for example, presence of fetal anomaly on postmortem or previous unexplained IUFD or recurrent miscarriage. So in this case, fetal blood or karyotyping is indicated. Okay, so indication again, fetal unbalanced translocation diagnosed, or it's recommended by the genetic counselor, or fetal genetic testing failed, but there is history suggestive of aneuploid. Okay? Maternal toxicology, when you will search for occult drug use. With consent, if the history or the presentation are suggestive, and in this case, urine is efficient and effective, nails and hair can be used. Meconium toxicology also may become widely available. Okay, yes, history suggests. Fetal and placental microbiology, like fetal blood, fetal swabs, or placental swab. This is to detect fetal infection. Okay, this is more informative than maternal serology for detecting viral infection. Cord sample can be taken in, if possible, in lithium heparin. Written consent advisable if cardiac blood, okay? Cardiac blood scan can be taken by the histopathologist and used for bacterial culture, or need to be obtained using a clean technique. Please remember this point, okay? So we are screening for fetal infection by fetal blood, fetal swabs, and placental swabs. Fetal and placental tissue for cytogenic and possible single gene testing. This will be taken from the fetal cord and placenta, okay? And the advantage of it, it will be for searching for aneuploidy or single gene disorders, okay? Post-mortem examination, either external or autopsy, microscopy, X-ray, placenta and cord, or ultrasound scan, genetic, MRI can be done, okay? And the evidence, of course, of it, it can be very helpful, okay? And it can help us to find the cause in 50 to 75% of cases. Maternal random blood glucose, okay, this is to find if there is any risk of diabetes. Maternal hemoglobin A1C, this is for undiagnosed maternal pre-existing diabetes, okay. Maternal thyroid function, okay, by testing TSH, T4 and T3, the free type, of course. Maternal thrombophilia screening, indicated to screen for APS, especially if evidence of FGR or placental disease. Antiphospholipid screen to be repeated if abnormal. Advised to include antibodies against the beta-2 glycoprotein 1 or lupus anticoagulant and anticardiolipin antibodies in antiphospholipid syndrome. Okay. How about inherited thrombophilia screening? Will you advise inherited thrombophilia screening routinely to all cases? Not routinely advised, okay? Anti-red cell antibodies serology, this will be indicated if you have fetal hydrops, okay? Maternal anti-Rho and anti-La antibodies, okay? This is to search for occult maternal autoimmune disease. This is indicated in cases of evidence of hydrops or endomyocardial fibromatosis or AV node calcification in the postmortem. So according to the finding of the postmortem, then you can run maternal anti-Rho and anti-La antibodies. Maternal alloimmune antiplatelet antibody, okay, indicated if there is fetal intracranial hemorrhage found in the postmortem. So this is indicated testing, right? So the testing that it has an indication, you need to know for each test, what is the indication to do it. Some cases, okay, when we say this is for all, right? When you will do maternal standard hematology and biochemistry, including CRP and bile salts. Reason for the test is preeclampsia and complication, okay, cases of sepsis or hemorrhage or hepatic polystasis. Platelet count, additional comments. This is for platelet count to test for occult DIC. If abnormally low, discuss with the hematologist and suggest repeating according to advice. Maternal coagulation time and plasma fibrinogen. Is that a cause for late IUFD? No, so I'm not doing this for detecting cause. But why I'm doing this? I'm doing this to detect the DIC. Risk of the DIC increased with cases of placental abruption or maternal sepsis or preeclampsia. So in this case, I will be very alert right? To find out, okay, if there is any possibility of DIC before even advising a waiting, right? And it's especially important, okay, for regional anesthesia use if has been an interval more than 48 hours since the IUFD until birth. Clay-Howard testing, will be done when? For mothers that they are Yes, excellent. Well done for all. Yes. Yes. So the Clay-Howard testing should be recommended for all women, not simply those who are Rh negative. Okay? Ensure that the laboratory aware if the patient is Rh positive. Test should be undertaken before birth, as red cells might clear quickly from the maternal circulation. In Rhd negative women, second Clay-Howard test also will help, okay? Especially if it was large fetal maternal hemorrhage first diagnosed, right? So they said as soon as possible when to take the test, as soon as possible after diagnosis of fetal death, or in cases of delivery, it will be within 3 hours from birth, not before, not after this, okay? Maternal bacteriology, okay? So if you have maternal fever or flu-like symptoms or abnormal liquor, okay, or prolonged rupture membrane before the late IUFD, okay, then please run the blood culture and midstream urine, vaginal swab, and cervical swab, okay? Suspected infection, including the listeria and chlamydia, need to be ruled out in this case. When you will take the swabs, as soon as possible after diagnosis of fetal death. How about maternal serology for viral screen or other tropical infection? For undiagnosed maternal fetal infection, store the serum from booking test can provide baseline serology, and you can compare between that sample that you taken before the discharge, okay? So you can check and compare between the stored booking sample and the one that obtained after, the diagnosis of the IUFD. Okay, friends. So I know that the tables of the testing or the serology required is a bit lengthy, but it will be interesting if you go through it. And finally, I will advise all of you to go through the patient information leaflet, especially if you are attending the OSCE exam, the Part 3 exam, or any other exams in the gynecology, obstetric and gynecology. Okay, why? Because it can give you a good way, okay, or like answers that you can answer to a parent who are having this situation. Remember, if this is a breaking bad news, and you should show the maximum empathy to the patient, right? Respect as well, and you have to take care of the tone of your voice and about the how you speak and how you answer. Every word that come out from your mouth will count in this situation. I know it's a difficult situation, right? But you have to train yourself on how to deal with it, okay? Our specialty, unfortunately, sometimes we face this tragedy in real life. Okay, so you have to be prepared also on how to counsel a parent who lost a baby. So about this patient information leaflet, being told that baby had been died before birth is devastating for the mother and for the partner, okay, and also for other loved one. This information leaflet is for patient who lost her baby and or died before the birth, but after 24 weeks of pregnancy, which will be called a stillbirth. Okay. The key point is emotional support, okay, that it should be provided, okay, when the baby died, and the healthcare team will support you, and additional support is available from a number of other organizations. You should know also like 1 or 2 names of the organization that provide support to parents who lost a baby, like the Saints, for example. It is up to you to decide when and how to birth your baby. Your healthcare team will give you the information you need to help you decide. Vaginal birth is usually recommended, but the decision is yours. You will be supported after the birth to spend time with your baby if you wish, together with opportunities for memory taking and help with funeral arrangement. You will be offered different investigation to try to find out why this has happened. Unfortunately, the cause may not always be found. You will be offered a follow-up with your healthcare professional to review the result of the investigations and make a plan for care if any future pregnancies. Okay, so guys, please be careful, okay, about this. The possible question that the patient might ask in the exam is, why might my baby have died? Okay, which is unfortunate event, happen in 1 in 250, okay? And unfortunately, it's not always possible to give an answer. A cause can be found for around 2 out of 3 stillbirths, as I told you, from 50 to 75, when investigation have been performed. The most common cause is something has prevented the placenta from providing everything that the baby needs to survive. Okay, so possible reasons for that, like infection or complication from diabetes or early separation of the placenta or a preeclampsia. Okay, sometimes the baby have underlying genetic or physical condition that caused them to die. Rarely, something can happen during labor that might lead to the baby death. Okay, so they might ask about the confirmation of the baby death, and this is by the ultrasound, of course. What happened next? Okay, so this is very important. Okay, about the healthcare professional will take you to you and your birth partner will talk to you about the death of the baby, and they will check to make sure that you are physically well. For example, making sure that you have no signs of infection and your blood pressure is normal. Then they will explain to you your choices of birth and various tests that can be offered. Okay, you will be given information, support, privacy, and plenty of time to help you make your decision. You will be encouraged to have your partner or anyone you choose with you. The choices of birth, of course, this will depend on the general health and the condition of the mother, but we will recommend the vaginal delivery. How will I give birth to my baby? Okay, so again, you will give choices to the patient. This is information about induction of labor in cases of the IUFD, okay? So the patient might have to choose to start the labor as soon as possible after confirmation of the baby death, okay? Or some patient may be preferred to go home for a short time before, giving birth. There is an option of waiting, of course, for the natural onset of labor, okay? And your patient might ask about it. If the patient have a cesarean section before, okay, so it's usually safe to induce labor, although it's not completely without risk. Okay, so you have to speak about the risk, as we said, my dear friends. Okay, so if the patient have more than one previous cesarean birth, the risk of induction of labor increase, and cesarean birth may be advised. Okay, and there is also here a patient information leaflet for the VBAC. What happened when my baby is born? Okay, so you will be supported by the healthcare professional looking after you and your partner, and sometimes other members of your family may wish to see or hold the baby immediately after birth. You may like to wait to see your baby until little later after birth. Okay, you may decide not to see your baby at all. Okay, so the patient might wish to see and hold the baby hands, maybe have time or an opportunity to spend time together, maybe to take photos. Okay, maybe she want to choose to name the baby and or dress the baby in their own clothes. Okay, so this is will be also offered. Okay, what happened after my baby has been born? Okay, so a member of the bereavement team will talk to you and your partner about the funeral choices for your baby and about the registering the stillbirth. Any religious and cultural preferences you have will be respected, okay? And the spiritual support will be available as well. So my friends, remember when we speak to a patient in the part 3 or in the OSCE exam, okay, you have to answer based on the UK practice, right? So the details of what you will do, or if the patient asked about the funeral arrangement or about taking memories from the babies and all, this is, you have to answer based on the patient information leaflet or the practice in the UK, okay? The patient will be offered, of course, after the delivery, okay? She will be offered the postnatal visits by the midwife to check the recovery, okay? And to provide support and to talk through any question that the patient might have, okay? They will check on their own health about the bleeding, discharge, presence of fever, any soreness in the legs, okay? So the investigation that the patient might be offered, this is a very important question. It's about, you will be offered investigation for you and your baby that might help you to find out why your baby has died. A cause is found up to 2/3 of stillbirths. Remember that in previous version in the guideline, we used to say half, okay? But now you will say 2/3. Understanding why your baby died could help you and can help you planning for your care in the future pregnancy. Unfortunately, despite investigation, some deaths cannot be explained. Some investigation may cause a delay in the funeral arrangement as well. Okay, so both parent will be given time, okay, to think about the investigation, okay, and maybe ask more questions, okay. Very important that they will need to sign a consent form for some of the investigation. You will be offered an appointment at later date to discuss the result. Investigation that might be offered, very important, my friends, here, test of the baby chromosomes, okay, which involve a sample of the placenta, umbilical cord, or skin sample from the baby. This test is important because approximately 1 in 17 of the stillbirth babies have a problem with their chromosomes. Sometimes more detailed genetic testing are recommended. Post-mortem examination for the baby, either it's a full or limited, it has to be offered, okay? And here, for further information on post-mortem examination, you will advise the patient to go to the SANS website, okay? And the patient information leaflet that we will offer also will be the RCOG patient information leaflet or the SANS leaflet, okay? Blood tests to look to a number of conditions, including pregnancy-specific problems such as preeclampsia or obstetric cholestasis, diabetes or maternal infection, or condition that can make your blood more likely to clot, like thrombophilia or antiphospholipid syndrome. So those are the tests, okay, that will be added. We also will have a chance for discuss the infection if suspected infection is seen, okay? The extra care in the future pregnancy will be a very important point that you will never miss. That's all, my friends, for the new update of the guideline. You can see that there is a lot of the things that are common with the old version, okay? And the few points that only have been changed.